And we're back. We have Jon Hodges. Jon, thank you for coming on. For people that aren't familiar with you or Nevada PT, can you give a brief intro on yourself?
Yeah, thanks for having me, buddy. Yeah, I'm one of the co-owners of Nevada Physical Therapy based out of Reno, Nevada. We have 3 locations out here, born on the University of Nevada's campus. So we were there for about 27 years until we moved into our new clinic kind of midtown. So focus on, sports and orthopedics. And most of our niche is in the testing realm. So obviously like protocol development, return to sport testing, things like that. So yeah.
Yeah, I did my final rotation with Jon in Reno for shortest rotation of all time. It was like 3.5 weeks. Come and gone very quick, but I had a phenomenal time, and I have a ton of respect for you and Nevada PT and the protocols you've created, and that's what we're going to dive into today. You spent a ton of time diving into the hip arthroscopy research and creating a phenomenal protocol and guideline for patients and for clinicians that I want to tag and include in the show notes. Let's start out with one, why you decided to dive into this specific topic and this surgery, and your starting point for chipping away at the protocol itself.
Yeah. So honestly, what happened was I think I started working on this like 2020, maybe like 2021. But it came from honestly, like I didn't feel like I knew much about it. So I was getting these post-operative patients. I didn't really have a good grasp on just kind of how to manage them. And I was doing the usual like kind of new graph. I was just following whatever the doc's protocol was. And as I started seeing more of them, I started kind of going into the research to try to see like what were the outcomes and like what were people doing. And once I started that process, like it became a like landslide. I mean, I there was maybe a half dozen published protocols. And for the amount of post-op hip arthroscopies that we were seeing, I mean, it was just kind of shocking to me that there was like such little information out there for people to kind of guide clinical practice. And I mean, you figure compared to the things that we're known for, which is typically the ACL protocols, where there are tens of thousands of papers. And I mean, I don't think they're even publishing new ACL protocols because we've just done so many over the years that there was just nothing out there. I mean, it was all conjecture. If you found it, there was no objective testing. And we'll get more into some of those things as we go. But that's what started this process. So when I realized that there was such a little amount of information to guide people, I had to go and read everything I could find and start trying to basically assimilate this into some sort of usable protocol that could actually guide other people. So that's where we started. I mean, it took me over a year probably to put this thing together. So slow road because there weren't a lot of streetlights, if you know what I mean. You know,
Yeah, what immediately stood out to you? Was it just the unfortunate nature of there's just wasn't a lot out there, or was there anything that you did look into that you were like, oh wow, I would have never guessed that this was that way?
yeah. So first, there was just a lack of information, right? So just trying to even find protocols that were published was difficult to begin with. But then when I actually started getting the protocols, I mean, there was almost no consistency through these protocols. I mean, like there was a couple of like small running themes, maybe some like range of motion precautions, like the first 3 weeks. And it's kind of the classic, orthopedic protocol where like they're very detailed for like 4 weeks or for like 6 weeks, and then it's like start running and ease back into sports. And so when I started seeing that even of the protocols that were out there, there was no consistency. And you would see papers, I think like Svitanovich, he actually did a review, and they've done 2 or 3 of these reviews since, and it's the same thing. Every single paragraph starts like there is considerable variability in X thing, right? Whatever they're looking at. Range of motion restrictions, which we think would be pretty straightforward, we're seeing maybe like a 48%, consistency. So not only was there very little information, but the information that was out there was all over the place. And for me, that tells me that if there's that much variability, nobody knows, right? There is no information right now that we're basing decisions off of. And what most of the kind of framework came from was borrowing from ACL research. I mean, they were taking most of the studies that, if they even referenced anything, they were referencing ACL studies.
Now that you have that assimilated that information, you realize that is kind of a shit show. When you are interacting with patients that either they've seen a surgeon and the surgeon's recommending the procedure and maybe they haven't decided to get it yet, or they are asking your thoughts, should I get a hip arthroscopy? What does that conversation look like? What are you providing as these are some of the reasons why we may go down this path, or these are some of the reasons why we may want to hold off and trial continued non-surgical management?
Yeah, and I think typically what I'm looking for is what are they trying to get back to, right? So if these are like certain athletes, like maybe they're trying to get back to hockey, or they're D1 baseball catcher, or they're ballet. Like certain sports are a little bit more difficult for that, and it's the same thing when you look at actually like base rate studies. I mean, most of them are going to be in like hockey and ballet and some of these kind of classic sports. So I'm usually looking at what they're going back to. I would say the majority of people, though, that I see that come in to see me with a hip labral tear, or people that are, they're weightlifters, they're hikers, they're people that are going back to just sports that I think typically they can do well with. So most of the time, we're recommending a conservative course, right? So we want to start, 6 to 8 weeks of good, consistent work with, scaling aggravating movements. I found over the years that there are kind of like the classic 4 or 5 things that I see, which is, and there's some papers that support this, that I think there was about 1/3 of individuals that were getting hip arthroscopy had glute med tendinopathy. And it's chicken and egg, were they unloading the hip because it hurt, where they it was that part of the problem. But either way, we see this in the post-operative side too, that like glute med weakness was a constant thing that we saw. So getting people to get stronger through the glute med. Typically most of these folks were like repetitive hip flexion folks, right? Cycling, hiking, things like that. So we would get them into movements like a rear foot elevated split squat, reverse Nordics, some of these things where we're trying to get them into a longer hip position. And most of the time, I'd say probably 75%, 80% of the time, they do really, really well. So I give them kind of an idea of like typically 75 to 80% of people, they can manage this non-operatively, depending on obviously the sports they're going back to. Maybe 1 out of 5 or 1 out of 4 end up going and pursuing surgical intervention. The other part that can be a decider can be the structural things, right? So hip dysplasia, obviously the instability that comes along with that. If they have a very significant, so they're looking at alpha angles and some of these other kind of more specialized imaging, some of those angles can dictate their outcomes too a little bit more, right? So if they have a lot of, coverage of the acetabulum over the glenoid, we're having a hard time. These are the guys that come in and they have like, 40 total degrees of range of motion, but they might be like CrossFitters or jiu-jitsu or something like that. So those are typically the things that I'm looking at, but there's nothing really like special about the hip compared to the way we do this with everything else, right? ACLs, maybe partial thickness cuff tears, or, labral tears in the shoulder. I'm looking at, what is their level of function? What is their training history, and how sensitive is this? And then it gives me an idea of how do they respond over that first few weeks or that first month of how this is going to go.
And if they are wanting, and the decision is to receive the arthroscopy, what are the things you're educating them on the reality of the timelines of return to sport and the return to sport rates? Maybe there's unrealistic expectations or things that they assume they're going to get back to, or at this timeline. What do you typically discuss there?
Yeah. So the hip is unique compared to maybe some of the other, traditional like orthopedic sports, injuries that we see, especially like, from a surgical standpoint, an Achilles rupture or an ACL or, something like that, where these are athletes that have been dealing with pain for a long time. So I think on average, they have been experiencing hip pain for like 11 months before they go and actually like seek surgical intervention. So they are dealing with a lot more of like the psychosocial side typically compared to other deals. So we're tracking, anxiety. They haven't been able to do the things that they've enjoyed for a long time. So there's a lot of hope that's attached to this surgery, right? That the surgery is going to get them back to doing the thing that they want to do. And I think we see it with the ACL research that there is a mismatch in expectations on getting surgery and what they're going to go back to. And the ACL, right? It's like 93% of people think that if they get ACL reconstruction, they're going back to doing the thing that they were doing before they got hurt. In reality it's probably somewhere around 60-65%, right? Maybe it's getting a little better, 70%. And the hip arthroscopy guys, if you read any paper, like they open with the classic, 87 to 93% of people that get hip arthroscopy return back to sport. I mean, that's like Nobel Prize level orthopedics at this point, right? Like just a couple little tweaks and we should be hitting 100% here. But guys like Mike Ryman, they've gone in and actually looked at this research, and that number just kind of keeps going down. So the lowest I've seen was 17%, which seems very like doom and gloom. I don't think that was a good paper. On average, I think it tracks similarly to the ACL, that we're probably seeing around 65% of people going back to the same level and, the same, effort, and it addressed the, whatever the issue was that was limiting them, is probably around like 2/3. So I set that expectation. I think when you have clinicians that are more evidence-based, that have a better understanding of this, that number is better. Like I would be so bold as to say that we are probably around 80% with our ACL return to sport rates. You know what I mean? I think we are a standard deviation above what we're seeing in papers. And I think we do a good job with the hip arthroscopies as well, because like the point of this podcast is I agree that there are not a lot of clinicians that feel confident in managing a post-operative, hip patient. So I set an expectation that there's somewhere around 65 to 70% return to sport, that I think we do a little bit better. That the first, the precautions of what activity is going to look like, that first month, the first 3 months, and that the return to sport, one of my favorite papers was about the mismatch in expectations between, post-op hip arthroscopies, where everybody is told they're going back at 4 months. And we just don't see that, right? We see like the professionals might be getting back at like 5.5, right? They might be on the earlier side, with the exception of endurance athletes, right? Those guys can actually have a harder time getting back. So I tell them it's about probably 7 months, and it's normal to experience hip pain off and on through this process, because what we see is that they're 4 months out and they're still getting, random flare-ups, or the hip still gets irritated. There's certain things that they don't tolerate well. So I set a lot of those expectations early as far as where they're going to land at the very end, what the first month looks like, X, Y, Z.
Is there anything else pre-operatively that you're discussing or that you want to chat about before we dive into these immediate post-op considerations?
I mean, if they've already made the decision to like go forward, like we've either done, a course of like conservative management and that just didn't get them to where they were going, then typically I'm making sure that we're tracking like the mental health side, right? They are usually very, very frustrated at this point, right? There's a sense of despair. So I am trying to create, a more optimistic approach that, people do well with the surgery. You've done all the things, we've gone in strong, right? Like, I mean, the whole point of this, like 6 weeks or 8 weeks, was to get these, most of the programming that we do is trying to like shore up the things that we see post-operatively, right? So glute med weakness, hip extension weakness, maybe sensitivity in the front hip, whatever it is. So they are going into this in the best possible, scenario, right? They're already stronger than they were than when I saw them, and we're already tracking the things that we're looking for afterwards. So they are set up for success on our end, and just trying to give them, some positivity, but also the other things we just talked about, right? I mean, we're 65 to 70%. So I had one of my patients, she asked me the other day, she goes, I read through your protocol, and it seems like it's all kind of made up out there. Like she like almost went the other way, where she's like, hey, you guys are all just kind of making it up. I'm like, kind of. We are using like science to guide this process, but I will agree with her that there isn't a lot of good information yet. And I think we're slowly trying to see things get better, but it's still bad. There was a paper, a protocol that was published last year, and I'm not knocking research. I know how hard it is to publish research, but it might be hands down the worst protocol I've ever read. I mean, there's not a weight to be seen. It is so conservative that they don't have people running until I think like 5 months. I mean, it's just a brutal, and like that's where we're at. This was last year, and the best protocol that was published is one of the worst ones I've ever read. And they actually got a letter to the editor like immediately from like other researchers, because the pendulum's swinging too far. So tangent, but yes.
Well, let's talk about a better protocol, y'all's protocol.
The best protocol.
The first month or so, this early phase management, early post-op considerations in rehab, what are the immediate things that you want clinicians to think about, and that you want to discuss with patients, from weight bearing status, from day-to-day activities? Where are you starting?
So yeah, the hip arthroscopy guys are similar to ACL. Like I want to get them in within 72 hours. So I want to see them early. It's for a lot of reasons. One is to try to get them moving early, right? So early motion is really important with the hip arthroscopy guys. They have range of motion precautions. So again, there's not a consistent, restriction across the board, but the trend is that we see that they are in a post-op extension brace. So they're limited in extension. So 0 degrees extension, 90 degrees of hip flexion, and then you will see some variance, typically, at least us, either a 0 degree external rotation restriction, which comes out of Mark Philippon's group out of Colorado, or a 20 degree external rotation restriction, which is more of the guys that train at Safran out at Stanford. So the hip surgeons in Reno, usually they all train under one of those two guys. So like there will be some like variance as far as external rotation. So they'll have a post-op hip brace. We talk about making sure that we are following those precautions, because those precautions are actually in place for the capsule repair. So it's actually not about the labrum repair. It's about protecting the capsule repair that they do. And those are usually going to be there for about 3 to 4 weeks. So precautions, and then early motion. They're on the bike typically day one, right? So I know at Vail, at Philippon's group, they wheel the bike into the hospital room. I mean, they are on the bike like that next day. So getting them on the bike early within their precautions, and then getting them going on motion. One of the things we're trying to do is minimize potential like scarring of that capsule to the labrum. And these are folks that you'll see that might have like anterior hip pain, like impingement type symptoms, like 4 or 5+ months out. So we're just trying to get easy motion. I think you're seeing a pendulum as far as all of like post-op orthopedics currently, which is less is more early on. I know I was part of that group where, the ACL guys, we had them, when they could tolerate it. I mean, they were doing lunges and squatting, as soon as we could pretty much get to it. Where I've gone a little bit more conservative with those guys and really kind of focusing on getting that knee to calm down and be quieter that first like 3 or 4 weeks. And the hip is the same. We really want a quiet hip. So those first 3 or 4 weeks, it's easy motion. There's some real easy like strength work within their precautions. And it's like 20 reps, right? 3 times a week, some easy mobility stuff. They shouldn't have a lot of discomfort. They should really have like minimal to no discomfort, So we're really making sure that we're tracking any pinching in the front of the hip, making sure that they are tolerating things well. So I think you see in about, this was like Adib, his group, 24% of people that had the surgery end up developing hip flexor tendinopathy. So precautions, early motion, and then managing that hip flexor. So what that looks like is typically, the docs, this one you'll see pretty consistent across the board right now, that they want a foot flat posture, right? So they want them walking, they want a foot flat, 20% weight bearing, and they're on crutches. Now, I've had conversations with multiple surgeons that the research does not support that you have to go in this partial weight bearing phase. Like it actually, all the research that's come out over the last like 4 or 5 years says that there is no increase in risk of them weight bearing as tolerated. So I tend to be a little bit more lenient on the crutches, right? So I'll usually have, a week or 2 where I want them to kind of use those crutches. But if they're feeling pretty good, I will let them start progressing out of the crutches, even though they'll still have the extension brace. And the docs all know. I always run it by the doc. Hey, they're doing great. Can I get rid of the crutches? And most of the time they'll be open to those conversations like, yep, absolutely, it's doing good. Or if they might have done something like a microfracture, there's some sort of like, additional intervention they did, then we might go a little bit slower on the weight bearing. But those are my general first 3 or 4 weeks. Everything should feel good, frequent motion, and then protecting the hip capsule repair. Those are our main goals.
And then what are you educating patients on in regards to, let's say they're students or they have a specific job where they have to be in specific positions for prolonged periods of time? What are you trying to educate on minimizing those hip symptoms throughout the day?
Yeah. So The general recommendations, like, we don't want them to sit for more than like 30 minutes to 60 minutes at a time. So sitting tends to be one of those like kind of aggravators for the post-op hip folks. Um, everything has to feel good. So like if walking, right, if they're getting irritation in that hip because they're trying to hold that hip a lot more, right? We want to make sure that they're trying to offset this. So this is like having, a small child. We're getting into tummy time, right? How much tummy time are you getting? And we want them to be able to get into these positions where they're not in hip flexion, constantly. So they might have to sit a fair bit for work. Then they need to get up and stand. At home, we want to make sure that they're spending time on their stomach. We get into a modified Thomas stretch day one, right? Like getting them into some of these just hip positions that can offset the activity. So if they are getting aggravated with walking, things will get a lot more difficult. So, like at the university, it's a lot of hills. So, most people are actually, as we transition out of this phase, those first 3 or 4 weeks are doing great, but then they're getting off their crutches, and now they're starting to peel off like miles on campus, and they're hiking hills. That's where we'll typically see a lot of the hip flexor irritation show up. So, it's making sure that they're aware that they need to be tracking that, the front of the hip pain. If they're getting more of that, they need to make sure that they're trying to get enough to offset it. And most of the time, they're just not getting frequent enough, either Thomas stretch or, the tummy time, prone on elbows type positioning. If they can manage those things well, then we can kind of progress to our next phases. But if they're still dealing with a fair bit of hip irritation, we will slow things down because we don't want to just keep throwing things on top of it. Because all we see is it just keeps getting irritated. So the hip joint is unique as well because the reason why they do a labral repair. I don't think we even talked about like, why are people going into this, right? So, you have cam or pincer morphology, right? Typically it's hanging up mechanically on the labrum and they tear the labrum. But we see asymptomatic, labral tears all the time in sports. But the reason why they'll go in and do this, obviously from a pain intervention, but it disrupts the suction seal, right? So that hip joint is such a tight system that when they have a tear, it takes less to distract the joint, right? So they have more instability. And the dysplastic type folks, like those can be different conversations because they can be starting to look into more of these, derotational osteotomies. So the point is, they go into this because the suction seal is what they're trying to restore when they do a labral repair. When you irritate the hip, because that system is so tight and it's such like a tight hydraulic system, it can be harder to calm down than other joints. So if they irritate it, it can take us a good week or 2 weeks just to get back to baseline compared to maybe like a couple of days with like a knee replacement. So it's something that we're a lot more mindful that we are more conservative and they're tracking this. And we're not trying to put fear in them. We just want to make sure that if they are developing anterior hip pain, or things are getting either they're trying to push it too quickly, it's going to slow us down in the long run.
Is there anything else in these first few weeks that you want to touch on or that you think is very important for clinicians to think about and do or not do?
I mean, I don't think there's anything different. It's just kind of highlighting. The capsule repair has been the biggest change that you've seen over probably the last 5 years. I mean, I'd say probably 7 to 8 years ago, I mean, you were seeing maybe like only a third of guys were actually repairing the capsule. And the majority of people were leaving it open. But now the clinical practice guidelines, I mean, we do restore the capsule. So if anyone's not restoring the capsule, that is an out of date practice. So like reading through the actual, the operative report. Obviously, they come in typically in an extension brace. That's a sign of a capsule repair. So protecting that capsule early on is really important. Getting them moving and then making sure that they understand what is the goal here, right? We don't want to be irritating the front of the hip. Everything should feel good. This is not your classic linear progression where you're going to do, I mean, it's 20 reps and that's it. I want you to feel good.
Now, this phase 2 that you all write in the protocol, 5-ish to 12 weeks, what are now the new goals and what is progressing past this early post-op management phase?
Yeah, so we've gotten out of maybe the capsule, precautions, right? So they've gotten rid of their extension brace. They really don't have range of motion restrictions at this time anymore, right? So now it's all just kind of slowly progressing their passive range of motion. Same rules still apply though. I don't want anterior hip pain when they're working on their, internal rotation or their hip flexion, right? We're still going to be really conservative as far as their experience there. But we are now starting to get into lifting, right? So you look at some of the labral strain profile studies. I mean, there's like I think 2% strain with squat. Right. So there isn't a lot of strain that we actually put on the labrum with most of the exercises that we do. So typically we're getting them, they've already been into some sort of like weight bearing progression, right? Because they're getting off of crutches and I've already shared, I don't really concern myself too much with the limited weight bearing as long as doc's on board and that they're tolerating it well. So now we're starting to get into, RDLs, two leg RDLs, single leg RDLs. These are all typically graded based on their tolerances. We start off with the reverse lunge, right, pattern, two-step drill. So just starting to get them into some single leg kind of positional holds where the other leg is doing movement. So whether it's standing hip abduction, a two-step drill, then we're getting into more of our like traditional like kind of compound lifts, right? RDLs, some single leg RDLs, and then we're grading exposure with our squatting and our reverse lunge. And we use like a heel elevated squat as usually our entry point. We used to use kind of like a TRX squat, but I think if anyone's ever taught the TRX squat, like it looks like you're teaching water skiing. You know what I mean? Like they are 80% back, and if that thing goes, like they're going the other direction. So I've kind of gotten away from the TRX type movements and just put them up against a wall, feet on a couple dumbbells so they're elevated, and just having them do kind of wall slides or like knee bends. So and then from there we transition into a traditional heel elevated squat. The big shift, I think Philippon's group is the one that has a no resisted hip abduction until 6 weeks. But when I've had conversations with other surgeons, that seems to be pretty unique to them. And I think it just comes from their experiences as far as like progression. So I am still a little bit more conservative on resisted hip abduction until around that 6 week mark. But if you ask me why, I'd say because Philippon's one of like the top guys in the country, and this is how he likes to do it, and this might change. This might go the way of knee extensions with ACLs and things like that. We are looking for starting to kind of introduce them into the Faber position, and to get out of this phase. Our progression criteria is typically we want 50% of the Faber position, so measuring from the knee to the table, and they should have generally speaking 90% or better passive range of motion pretty much in all planes. Although external rotation typically gets a pass, because we haven't been able to do any external rotation stretching for the first like 4 weeks typically.
That's 5 to 12 weeks, close to the 3 months time point. Are you doing any testing or check-ins closer to that 3-month mark before you move into the next phase?
Yeah, so like for the progression criteria, I want to see typically, 80% or better on my muscle testing. So like hip abduction, adduction, hip flexion, right? Those like kind of your traditional either handheld dynamometer or inline dynamometry. I want to see them be in that like 80% range. We do a Y balance test. We want to see them like less than 8 centimeters before we progress out of that 12-week or that phase 2 model. It depends. Like we're talking about hip arthroscopies, but we're kind of talking about labral repairs. So if these are FAI decompressions or like labral debridements, I'm usually, and they're doing pretty well, I'm strength testing them like at 8 weeks. So I'm testing them a little earlier, and there's no real reason for that. I think it's reasonable to test the labral repair guys at 8 weeks too. So we are typically serial testing as we go, and then they're doing side planks by week 5 or 6 typically. Week 6 on most folks. So they're already in a side plank position. So we are actually doing some functional testing too at that like 12-week mark, which is like a side plank, max hip. So they're doing hip abduction and some max reps test. We're doing a single leg squat test, and most of the protocols that you'll look at online, they use a single leg squat or a single leg step down as an assessment. I have a personal like disdain for like subjective testing, because it's literally, I think for the single leg step down test, the criteria is like your general overall impression. So like, I don't like, are we dating? Like, I don't understand what that means. You know what I mean? So I like things that I have numbers and I can like measure. And so I typically live in the dynamometry testing and then some like functional testing too, even though I admit that there is a fair bit of subjectiveness there.
How do you set up the dynamometry testing?
I don't know. Like I'm changing it constantly. You know what I mean? I feel like I'm trying to figure out my best testing. So this is an area where I don't feel like we, at least on our side, when you look at trying to use like torque calculations, which a lot of research is actually starting to put out, right? Like 2.6, Newton meters kilogram for a deduction. Like, so we're actually seeing metrics that are out there on what like, normative data should be for the hip. But this requires a very rigid setup, right? I mean, you're strapping the pelvis down, you're doing all these things. And so I think our testing is good, but I don't feel confident enough that it's rigid enough that I can like start drawing like torque calculations. But the way we set it up, I do a handheld dynamometer for hip abduction. I found that that's a little bit more reproducible and a little bit more accurate than the inline dynamometer, but I will use the inline dynamometer as well. And so typically they're in side lying. I have them straighten their leg and make sure that they're at least in 0 degrees of external rotation, if not even slightly internally rotated. And with the dynamometer around, the malleolus, I might be, fixing the strap with my foot. Handheld dynamometer, obviously, applying, a braking effort there. Adductors, we use the dynamometer more. So we set them up actually in our squat rack, right? And I set up the one foot is in an ankle cuff and just, tied to the rack. The other one is the dynamometer, and they're just basically doing like the watermelon challenge. So they're just like squeezing as hard as they can. And then we reverse that to get our numbers. Hip extension, I use a dynamometer, and then we're just doing, a prone straight leg hip extension, and I'm breaking them at the kind of like, 8 centimeters above the calcaneus. And then hip flexion, they're in a 90-90 position, and I'm actually handheld dynamometer pulling them until I can break them. So there's a little variance in our testing, and I'm still, because and the reason why there's variance is if I do the handheld dynamometer, I'll go with for hip abduction, for example, and then I go and I put them maybe in supine, like by the rack, and I have them doing a hip abduction test there. I'll see a fair bit of difference between those numbers. Whereas the other tests look more consistent, and they're more symmetrical, and I feel confident in those testing goals. So I think at the end of the day, if you're even using a dynamometer and you're testing the hip, you're already in like the top like 10% of PTs in the country. So from there, we're still trying to figure out like what the best test setups are. The last one is external rotation. So I set them up in prone with a 90-degree knee flexion, and we're going from the lateral malleolus, and it's a braking force, medially. And that test is handheld dynamometer, but I have seen setups where they'll use inline dynamometry. I just find it's like hard to get all the slack out of the system, and I spend so much more time trying to get the setup. So the handheld dynamometer is faster. The adductor testing with the inline I like better, and then our like side plank Copenhagen type testing. If that answered your question.
That does. Thank you. Let's go into phase 3. So 3 to 4 months. Again, what are the priorities within this phase, and what does eventually that progression criteria and objective test look like at the end?
Sure. So the phase 12, week 12 to basically, week 16, or whenever we're moving into the last phase, which is kind of return to sport. At this point, we're really focusing on training intensities, volumes, right? There really aren't any restrictions on lifts, right? We might scale like a power clean or something like more of the faster, more Olympic lifts. We might have to scale those a bit more still at this point, because most of what we've been doing up until that 12-week mark is typically, deadlifts, RDLs, squatting, overhead pressing, things like that. So we haven't done any of the Olympic variations at this point yet. So we're probably introducing more of like the quicker lifts at this point. We are geared up towards like returning to running and getting into our like maybe level 1 plyometric type skills. So I want them to be able to, complete the return to run program before we get into our like return to sport block. And this phase typically can go anywhere from 12 weeks to, 20 weeks. I mean, it can take a little bit longer for them to get all that, the strength back. So we want them, 90% across the board for all their dynamometry testing. We want them for return to running, we want them 70% for all the functional testing. So single leg squat. And we do the single leg squat the same way we do our ACL test. So it's we use 10% of their body weight We set them up to a box at like 70 degrees of knee flexion, and it's basically max reps through full knee and hip extension in 30 seconds. And we test the non-surgical side first, then we let them rest for like 60 to 90 seconds, and then we test the other side. And that test is the easiest test to pass for the ACL guys, because I don't think it's a true knee test. I think it's more of a compound and more of a hip dominant test. And then it becomes a little bit more sensitive for our hip arthroscopy guys. Side plank test, right? We put them in the side plank position. I give them, I block their foot so they can't slide. And I hold my hand down just a straight elbow. It's kind of like CrossFit, right? No rep. They have to touch my hand for the rep to count. And I give them kind of cues on what I'm looking for to try to minimize some of that subjectiveness. So making sure they're not externally rotating through the leg, making sure they're not breaking through, the trunk and the pelvis. And then we do, and then at this point, I'm introducing the Copenhagen typically gets introduced in this early phase, and we'll obviously test that too. So we're looking for like 70% for those three main tests. And then the Y balance, we're looking for, 4 centimeters, maybe 6 centimeters, depending on the person, before we move into our return to sport stuff.
That return to run, what does that look like?
Yeah, we use the Delaware return to run protocol. I personally think it's the best return to run program out there, mostly because it is straightforward, right? There are soreness rules, there are mandatory days off, there are, you know what I mean? So it gives athletes like a very straightforward program to follow. There are other variations of it. There's the month to mile test you'll see in some of the protocols. So we use that one. I think it works really well for most folks. They have a treadmill variation and a track variation, and it just keeps people from just arbitrarily peeling off like 3 miles, right? So if I run 3 miles, like it's right, I'm running to the urgent care because I haven't ran in 12 years, right? So like these arbitrary things are where people get it, because most of the people that we're seeing for this, endurance guys, hikers, runners, cycling, right? These really like they're on the high repetition type schemes. So straightforward Delaware running protocol works great.
All right. Phase 4, final phase, 16 plus weeks. What are the priorities? What are the goals? What does it look like?
I mean, goals return to sport, right? So that's pretty much what we're focused on. So at that point, we are now just bridging through all of our skill work and our strength skills. We use the Vail agility test as part of our return to sport criteria, although we don't follow the Vail agility rules. So again, highly subjective test. I don't know if people aren't familiar with it. You're giving them there's a band around their hips, like a sport cord. They walk out until they have a slight trunk lean, and that's where you put a piece of tape. Then you measure the distance from their trochanter to their malleolus, and that's your other piece of tape, right? So further away from them. And they are jumping single leg to single leg, the surgical leg to surgical leg, tape to tape. And there's this whole rating deal. It's 4 points, right? Dynamic valgus and do they, their knee flexion angle and all these different things. But it's 100 reps. So it's a rep per second for 100 seconds. Like you're telling me you're rating a 4-point scale every second. There's just no way. So what I'm generally looking for, and we use this as part of our return to sport progression, right? So they're going to do maybe like 20 seconds and then 30 seconds and maybe they're getting up to 2 rounds of 45 seconds. And I might have them do it once, right? I want to see if you can do it for 100 seconds. And what I'm generally looking for is can they have their center of mass stay over their ankle? Because what they end up doing is keeping their center of mass in the middle. So I want to make sure that they are actually getting that shift, that they're not having a big, the valgus moment, that they're just keeping a good athletic position. So I'm a little bit more loose on our subjective criteria. If they can hit those things and they can do a good effort, right? They're getting maybe, 85 to 90 reps, then we call it good. We use a 5-10-5. I still think just from an athletic test and the way our clinic is laid out is we got 25 straight yards. So that's our test of, change of direction work. But through the phase itself, I mean, it's a linear progression from strength work. We are shifting a little bit more of the volume. So same thing with the ACL guys, where it might've been 80%, lifting and 10 to 20% of skill work. That is trending more towards, a 60-40 or even 50-50 type depending on the sport they're going back to. Our plyo blocks are just our blocks. Like I kind of establish like where are we starting? What are the basic skills here? So an example would be, rear foot elevated split squat, then going into a Bulgarian split squat tempo, right, where they're going to do 20 seconds and they're trying to hit a rep per second. I give them like a 15 rep, goal as a minimum entry for this 20-second deal. Then they're doing Bulgarian split squat hops, and maybe we're doing some lunge switches. So we're just taking strength movements and then progressing them into skill work. And then from there, we're getting into higher efforts, higher demands, and obviously unanticipated stuff towards the very end. Does that answer your question?
That does, yes.
Right.
If it's not one of these endurance-based athletes and it's more of the court sport or field sport athletes, what does that return to practice look like? It's sport dependent, but how do you educate them, or what do those initial steps look like of return to practice eventually for a full return?
Yeah. So once they've hit, it's similar to the ACL guys, except we don't have them take quite as slow of a ramp. The ACL, we are really concerned about like re-tearing. That is not something you typically see in post-op, like in hip arthroscopies, right? You don't typically see labral re-tears. The only reason why not the only reason, but the general reason why you would see a re-tear in a labrum is that the surgeon may not have removed enough bone. So they were still getting a mechanical hang up there. So if these guys are moving well, we'll move them through a little bit more on a progression criteria versus like the ACL guys. Even if they hit their progression criteria, there is still a time component. We're still going to slow them down based on certain things, right? So if they can hit everything at 6 months, like we're not clearing them at that point. In fact, in the ACL guys, the better they do earlier, the more likely they are to get hurt, right? So we use the hip RSI, which is just a variation of the ACL RSI for psychological readiness. But in the ACL folks, if they do really well on the ACL RSI at 3 months, these are the guys that actually get re-injured. We want them to go not good, pretty good, good, right? And then excellent. We want them to move through those phases. With the hip folks, we do want them to be over like an 80% hip RSI because the psychological readiness is still really important, but we will move them through more along a progression criteria versus a time criteria. So we just don't have the same re-injury rates. We don't have those same kind of constraints on us. So once they're building into they've completed maybe this this last phase where we're doing high unanticipated skill work, we feel really confident in their ability to transmit force, all the normal things that you would do. They are at this point, they should have already be doing some participation. So if it's basketball, right, maybe they're shooting, right, they're doing some ball work drills, then maybe they're conditioning with the team. We start with offense typically. So with basketball, they can start running maybe offensive drills, and we give them time constraints, right? So in basketball, they can do offensive drills only. We don't want them reacting to somebody else yet, and it's 25% of their normal volume. And then from there, we're going to start stacking, 10 to 15% per week. We might do a little faster with the hip arthroscopies, right? Where they can go, 25%, 45, 50%, 75%, something like that. And that would be in practice. And once they're getting to around, 70% of maybe the offensive time, we start introducing more of like the defensive work. And that's generally our algorithm. For playing, we're going to usually run 50% of whatever their practice minutes are. Right. So if they can practice for 80% of their normal, they can play for 40%, something like that. So we just want to give them like constraints, because what happens in NCAA or D1 type scenarios, as soon as they look good, coach is like, you're good. And so we have to give them just these kind of very set deals, 25%, 50%, and then half of that in game time minutes.
Have you noticed a trend with the cyclists, runners, hikers versus the field and court sport athletes? Which is a more challenging return and eventual discharge?
So yeah, there's different. They're difficult in different ways, right? Obviously, the cyclists I think are one of the harder ones, right? Just the amount of reps that they get in, and it's all just hip flexor, hip flexion type work. So we always keep the rear foot elevated split squat and reverse Nordics. Those stay in the program the entire time for those guys, right? So Copenhagen's will, those guys, those will be throughout the entire program for maybe our, our hockey guys or, our contact sport guys. So we have a difference in kind of the movements we pick based on, what the activities are. In general, I would say like Ironman, endurance, cycling type folks are one of the harder ones. Outside of that, I don't think catchers in baseball, like the very obvious, like super hip, internally rotated, flexion type guys, they're just a little slower, but if they're not getting that anterior hip impingement type findings, in this last half, which they really shouldn't be at this point. At that point, if they are, I do have concerns of maybe some like adhesion of the labrum to the capsule. They should move through it pretty well. So I don't think that as long as everything went well during our program, they usually return and do really, really well. The only exception would probably be the endurance guys can be more challenging.
What have been for your own patients and your own kind of treatment algorithm? What was the biggest change from, I want to start diving into this literature, I feel either lost or just uncertain, till now you kind of have a better lay of the landscape? What changed the most for you from your own treatment perspective?
Yeah, I think the biggest changes for me over the last, maybe even the last 2 years, was that the first phase doesn't have to be this progressive phase, right? It doesn't have to be, let's make this, let's get some effort. I really want it to feel good. So it's boring. We try to get our excitement somewhere else, so we are doing a lot of maybe, floor pressing, maybe other lifts are going to get really good because I want it to be boring. And I got to get okay with not having to be, as a meathead myself, like not having patients always have to feel like they're just like constantly pushing themselves. So I've gone less is more in that first phase for sure. And then I was willing to have kind of harder conversations with surgeons, right? I realized that most of the surgeons, like a lot of these protocols are from their mentors, right? That and when you look at the research, like as I read through the protocols, I was like, oh, that's where they got this one. I mean, there was just a lot of, this is what we got from our guys and this is what we use. So I realized a lot of them are really open to having conversations about how to maybe do this better. Because if the PTs have no reference on how to actually do the PT side, that can promise the surgeons though, right? Like, I mean, there's just no one has a actual like footing to stand on. So I've had really like great productive conversations, and the surgeons we work with are surgeons that are great people that want to have a conversation, that are not these like kind of God complex type folks. They say, hey, I don't know why we do this either. Like, oh, how do you want to do it? And so the weight bearing, the return to sport testing, like those things that have been really fun for us. And from a business standpoint, like it's a marketing thing. Again, like there aren't a lot of PTs that are hip guys, right? That there aren't a lot of docs that have PTs, at least in Reno, that they're like, this guy knows the hip. And so I think from a young clinician standpoint, it is a niche that is wide open. I mean, if you dedicated some effort to getting comfortable with this research, I think you can really establish yourself in that community. And it's a great community. I mean, ACL gets all the love, right? I mean, you pull up Instagram, there's 10,000 people that are the ACL guy, but there's only, there's far fewer on the hip side. And there's similar deals. It's similar athletic populations. They're fun people to work with. There's a little more complexity. Like I find like ACLs are actually pretty simple. You know what I mean? Like they're pretty straightforward if you just kind of know what you're looking for. But the hip is a little more, it's a complicated joint. I mean, there's more things going on, and there's more variety as far as like the problems that you're solving. So I think it's a fun rehab program. It's not quite as boring, I think, as some of the ACL programs can feel. And I think it's an area that we're going to see a lot of improvement on the PT side, I'm hoping, over the next 5 to 10 years.
The protocol's already been out a few years at this point. Is there anything that you have already changed your mind on, either from kind of the narrative piece that you have during the beginning part of the protocol, or from kind of the phases itself that you're like, if I were to do this over, I would change this?
Yeah, I'm actually currently going through kind of an update on it. So I think some of the things that we've changed, or that I'm changing currently, or there were some things that were in there that I took from the Philippons group, or I took from other groups, because that's what I had. There was only 1 out of 10 was even putting out any kind of like progression criteria to begin with. So I was borrowing heavily from what other people were using when I first got into this. Now, when you look at it and they're using like a single leg squat or a single leg step down is like their primary, and this is true. There, that paper, there was a paper, I think it was the one I was talking about, the 2023 paper with Nasik, that their return to sport criteria was at 6 months. They went back to the doctor, they did a single leg step down, and then the doctor decided if they needed more PT or if they were cleared for sports. That was last year. So for me, it was borrowing less from what was already out there and going back to more of like the principles, right? We want to establish, we're seeing we have some strength norms on hip testing, and I want to get people back to those things more. So it's an increased emphasis on the strength side of things. It's making sure that we have force plates now, so that's obviously a big part of our return to sport testing across the board. So I'm able to look at jump asymmetries and things like that. That may not be approachable for other PTs if they don't have that, but for us, it's changed quite a bit. I mean, I can test guys and they'll be at 95%, for the ACL, for example, 95%, limb symmetry, and they're at a 3.0, Newton meters per kilogram, and they're still showing a 25% peak landing asymmetry. So it's improved my ability to pick up on things that I wasn't able to look for prior. I think your boy Q, he really made me focus on like, how are we doing our plyometric stuff? As a guy that didn't run, I was really just kind of winging it. And so now we actually have we built a skill tree, and I have a more kind of thought out process on how we want to get people through these plyometric blocks and what we're looking for. So I think, and this should be updated probably the next 2 months, I would imagine, just only because I know me and my ADD and, so when we update it, it'll have, I think, a lot more detail on the return to sport and the actual progression criteria. And within the protocol itself, I think I'm just a little, I allow a lot more in that mid phase, that 6 week to, 16 week. I'm a lot more open than I think I was really sticking to, the basics before.
Is there anything else that we haven't touched on that you want to chat about?
I mean, you didn't mention that I was a formative part of who you've become as an adult and a well-regarded physical therapist. But other than that, I think when you're a new grad, you still have to be a generalist, right? You still have to take in as much information in as many different settings as possible to try to get your skills up. But I think for people, once you start getting your bearings as a clinician, a year or two into this, is taking an initiative and actually going and digging into research on I started this because as someone who had been out for a decade, I didn't feel comfortable with the rehab. I didn't feel like I knew enough to help these athletes. And so I just started digging, and I started building it, and I started writing, and I encouraged like more people to do that, to actually just look at what they have their fear around and actually make that a strength.
I love it. Well, we're going to link all of your information below with the other protocols. There's the revised ACL protocol. I think there's rotator cuff. There's sounds like another revision to the hip in a few months. Thank you for all you do. Everything's so aesthetic on your website and the protocols. I use it with my own patients. I refer it to other clinicians. So yes, you have been a massive help, and you've been a great mentor. And I can't speak highly enough about NevPT. Y'all are crushing it.
People didn't know that you had hair until you came and did a rotation with me, and now you adopted this look. Like, they don't know that. You could grow it out if you wanted, but you and I are doing a thing. Speaking of aesthetics, buddy.
Weren't there patients that asked if we were brothers or?
Yes.
Yeah.
Multiple.
Classic. All right, Jon, we'll call it there. Thank you again.
All right, brother.